Pain notes.
Sir, we're in live, sir.
We are live?
Yes, sir.
Okay, thank you. Good evening, everybody. I extend a warm welcome to all the participants on behalf of Better Healthcare for today's webinar on COVID and concomitant infections. It's been more than a year since COVID has been detected, and as we all know that it shook the entire world. While precious lives were lost in the last 18 months or so, and economies were hit, the COVID has taught us many lessons, be it medical, social, or psychological. We had learned to adapt ourselves to the challenging conditions, and however developed we think we are, we were made to learn that a tiny virus can bring everything to a grinding halt. Though the impact of the virus may be less severe in India, primarily because of the steps that has been taken by the government and the initiatives they have taken up. And also, if you look at, we must thank the medical fraternity, the way they stood up in the face of adversity, at times keeping their lives at stake and handling the situation wonderfully. It's more than a year, and we are better prepared now when it comes to the management of COVID. Though the virus seems to be receding, but not without leaving a trail of its own. So today's challenges are more than providing treatment to the COVID. The challenges are in terms of understanding what are the complications and the issues that the COVID is going to create for the patients that are infected with this virus. And our today's talk on COVID and concomitant complications and infections are going to be addressed by some of the eminent group of experts who has done a lot of work in the last 1 year or so in the management of the disease. It's going to be a wonderful talk. I'm sure that all of you are going to get benefited out of with the experience of our speakers. So to start our proceedings, I'm going to introduce our chairperson. Can I have the slide, please? So for our webinar today, our chairperson is Dr. Rajiv Soman. He is a consultant ID physician at Jupiter Hospital, Pune, and Dinanath Mangeshkar Hospital, Pune. He is also honorary consultant infectious disease specialist at Hinduja Hospital, Mumbai. Dr. Soman has been a teacher for Fellowship of National Board Infectious Disease, Governing Council CADS, and Fungal Infection Study Forum. I think with their expertise in the management of not only COVID, but various fungal infections and concomitant infections, they're going to provide us some valuable insights in today's webinar. So I'll request our chairperson, Dr. Rajiv Soman, to start the proceedings.
Thank you, Nehru, and thank you, Hetero, for giving this wonderful opportunity. And as you said a minute ago, that COVID-19, really produced by this virus SARS-CoV-2, is a new disease, and it really took the entire world by storm. It's so remarkable that a virus could spread all over, and obviously that is related to human activity, societal changes, and so on. And it's really affected every aspect of human activity. It's relegated every other disease, infectious or non-infectious, really to the background. And while optimum ways to even to prevent as well as to treat are being studied at a very feverish rate, controversies are really springing up almost daily. The physician is often torn between wanting more solid evidence of safety and efficacy of treatment or even vaccines or the efficacy of certain tests and so on, versus the compulsion to do something for the patient in front of him. And in this context, I thank Hetero for having put together three outstanding faculty to discuss various aspects of the disease. Okay, the first faculty is, of course, Padma Shri Dr. Raman Ganga Khedkar. I think he needs really no introduction. If anyone had even switched on the TV for 5 minutes, I'm sure you would know who Dr. Ganga Khedkar is. And so he was the chief scientist, and in the early 80s, he began researching HIV/AIDS, which was really great news that time, and worked with the National Institute of Virology, National AIDS Research Institute, Pune. And he was active in developing national policies as well as patient empowerment. And the results are there for you to see. The results were there in HIV/AIDS, as well as you see that they are there today. All the predictions, Western predictions about HIV overwhelming India or even COVID-19 overwhelming India, I think did not happen. And Dr. Ganga Khedkar is definitely one of the persons who has contributed to this good state of affairs. He worked with patients at the government-run Potnis clinic in Gadikhana, serving disadvantaged HIV/AIDS patients. He became director in charge of the NARI, and in 2018, he was appointed head of epidemiology and communicable diseases at the ICMR and was really active, as I was telling you about, in this whole pandemic. He's earned recognitions like the Fogarty Fellowship from the NIH and Johns Hopkins University, and also fellowship from Switzerland. He was awarded the Padma Shri, the fourth highest civilian award in India, for his service and research in HIV/AIDS. I think all this also does not reflect what Dr. Ganga Khedkar is. And I think his talk on epidemiology and the messages which he will have for us will be more than whatever I can tell you about him. Welcome, Dr. Ganga Khedkar, and request you to start your screen share, and can Hetero do that? Okay.
Thank you, Dr. Suman, for introducing me, trying to tell what I must have done. But it was a big opportunity that I got. I think more than the routine policies that you have to influence upon, one of the tasks that I thought, when I reflect well, I think I tried my best to ensure that panic doesn't set in when the COVID-19 started off in India. Now, what I'm going to do is be quick enough, try to show as to what exactly is happening in India and what are its different implications as such. So as Dr. Soman said, the backdrop was that the world woke up to a harsh new reality in 2020. The first response to control the evolving pandemic was mostly through non-pharmacologic interventions, something which we had completely given away. Our memory tends to always be limited. For Spanish flu, and then came SARS, then came MERS. We tried practicing, but we never sustained those behaviors. Their repurposed drug testing and use of these repurposed drugs was essentially fraught with failures in the initial part of the outbreak. And you found that majority of the drugs fell out of favor over a period of time. And the result is very much there. When you don't have a drug, when you follow non-pharmacologic interventions which are difficult to sustain, the entire scene across the world is pretty disturbing. That within a span of 13 months, you find that close to 11 crore people across the world have been infected so far. And if you look at deaths, 25 lakh people have almost lost their lives in this COVID-19 in last 13 months. That's something which is a stark reality. Compared to rest of the world, if you look at our large population size, the number of cases that India reported continues to remain low. The deaths that are occurring are also comparatively lower if you have per million population rates applied here. Now, as I said earlier, when you rely only on non-pharmacologic interventions, if you look at what is happening exactly because of that, you find in different parts of the world, there are countries which are having second or third wave. Fortunately for us, what do we see? That in India, the first wave, which is a little protracted initiation of this pandemic, the sole reason was a longer lockdown that we tried implementing, and it was successful enough. And the bigger challenge at that point in time was that we didn't know how to educate such a large population in a very short period of time, given the fact that this particular infection is highly rapidly spreading infection. And then how do we handle such an outbreak as such? But the lockdown was one of the important strategies. Lockdown was accepted by people to a very large extent than one could have had imagined, and they accepted these non-pharmacological interventions follow up subsequently fairly well compared to rest of the countries. And that's the reason why we have first wave, which actually started almost 5 months later after the entry of this virus in the country, and then it is now on a decline. You look at USA today, you find that each wave that they had, it achieved higher peaks. And what was worse, that at a given point in time, they actually had more than 3 lakh cases occurring in a day. But what is a good redeeming feature? The US outbreak also is now on a big decline, and the drive to vaccinate is also strong in USA. Hopefully, in another 3 to 4 months' time, perhaps you might find that USA would have vaccination adequately done, the seroprevalence raised high enough, and USA will remain as a fairly protected country per se. You look at India, you find that the first wave started pretty late in July. And when it started, it achieved peaks, but those were comparatively smaller for the population size that we have. And now what you are seeing is a decline in the first wave. And but at the same time, we need to be cautious. The reasons we will come to know subsequently. Now, why do we need to worry at this point in time? The major worry that we have is, if you look at our past performance, when it came to the number of hospital beds that we required, we must thank our stars that lockdown provided us an opportunity to increase number of beds, increase ICU beds, also ensure that ventilation would be possible in different parts of the country, and even diagnostic tests could be offered in any part of the country. We had issues related to PPEs. You needed adequate supplies of PPE because PPEs were mostly imported in India at that juncture. If you look at even disinfectants, the supplies used to be less. Even we had to, at that point, we had to discuss even with the manufacturers of oxygen, and we had to ensure that oxygen supply could be adequate if we were handling large loads. Everything went well, but still when the first wave came, you find that the number of hospital beds that were required at a given point was fairly high. It actually ran up close to about 5 lakh hospital beds, 5.5 lakh hospital beds that were occupied in the peak. But currently, if you say on the right side, you will find that the number of hospital beds that are currently occupied is low, which confirms that the decline is actually has happened, because there are people who tend to say that the number of tests that you offer may be reduced, and that, or you are only going by rapid antigen testing, and therefore you are missing those numbers. But a decline in hospitalization would not happen without reduction in cases. You see a similar decline, but less in proportions of ICU beds or the need of invasive ventilators. And the sole reasons are very much apparent, because of late all of us have understood, we were lucky that we understood that ventilation is a problem in itself. high flow nasal oxygen is perhaps the best approach to actually manage these patients. And naturally, you found that our need for using invasive ventilation was comparatively lower than rest of the world, which is also reflected in the mortality figures that you look at. But look at USA and the number of hospital beds that are required as on 19 February today. No, you find that despite the fact that this population size of US is very small compared to India, it's almost one-fourth, but still you see the spike that they had, and they had to choose between patients who need to be hospitalized and and also select those who can still be managed at home in a worst possible way. And that's something which is actually disturbing, because we understand that with each new wave that tends to come, the wave tends to be having a higher peak than the first wave. And the reasons are very simple. The population that is vulnerable, the population that has not been exposed to this infection, if they keep on coming out of these practice of non-pharmacological interventions, you find that the numbers are more likely to be high in second or third wave. Within a month, perhaps, looking at that entire picture, it is possible that we may start with the most precious period globally to control this pandemic. And the reason is very, very clear. You find that excepting Brazil, which is yet to show a decline in the current outbreak that is occurring there, rest of the countries which are high burden countries are showing a decline. Perhaps in a month's time, you might find, maximally in a 1 month's time, you may find that all these curves will show decline, and the decline would be good for all the countries to work together and ensure that the second wave doesn't hit us. And India, fortunately, is also in the decline phase of this first wave. But there are issues that we need to understand. When you look at a national curve, it can always mask the heterogeneity that tends to exist. And this happens especially so for a country that has a vast geographic area like India. And the reason why we are discussing this is, though there is a good decline that you are seeing at this juncture, there are majority of states which show a decline. Maharashtra, Kerala, Karnataka, now Punjab and Madhya Pradesh are also appearing to be slightly different, and we'll try and see what exactly is happening there. If you look at Maharashtra, the daily infection curve that you might see, you will find that there is a small bump that we are witnessing as of now. Now, this bump has to be also understood in a better way. The way is, you find that the testing has also started declining a little bit in Maharashtra. So essentially, we need to be serious. There are reports that E484 variant has also been found in Amravati region. Now that's one cause of concern. But the best part is, when you have your numbers smaller, you can actually use every tool of contact tracing and also isolation effectively, because the public health force has smaller numbers to attend to and ensure that the disease does not spread beyond those districts as such. When you look at Kerala, Kerala presents an entirely different kind of picture. You find Kerala was one of those states which implemented the lockdown effectively. They had a comprehensive kind of a public health response that was in place, including community mobilization. And the result is very, very clear, that if you look at the curve continues to remain flattened. Their first wave is yet to be over. And that's the reason why you find that their numbers appear to be higher. But if you actually look at proportionate distribution of the cases, Kerala, Maharashtra sound to be having a significant proportion, but that may not be a very true picture for Kerala, because Kerala can continue to have this kind of a flattening for another 1 month's time, as it appears as of now, and then it will dip down in terms of the first wave as such. You look at Kerala, you find that the testing has not dropped down. the testing continues to be there, naturally they will detect more infection, and if they detect those more infections, the curves will also be influenced in similar way. You look at Punjab. Punjab is one state where also a small bump is being noticed of late. You look at the testing that has been done, testing is declining than what it was in the month of October, and naturally this becomes a cause of worry. You look at Madhya Pradesh. Madhya Pradesh is also showing a small increase at this point in time, and there is a huge decline in testing that occurs in Madhya Pradesh. So these states are actually trying to tell you that perhaps something is happening differently. Is it that the second wave is likely to strike to us? Or like Kerala, perhaps we may have some flattening, but these differences, geographic differences, are more visible because you are breaking down these numbers into smaller units, and therefore you see a lot of variation occurring rather than smoothing that you tend to see at a national level. But there is another worry that has come, that we know that new variants that can spread rapidly or escape mutants which are not likely to be covered by the vaccine induced immune response may pose an additional challenge at this juncture. Why do these escape mutants develop? Now, this is something which, if you think, was not something which is expected with the transmission dynamics that this particular virus has. You look at the fact that this virus tends to be alive in the body for a shorter period. Now, it still runs into days, maybe between 10 to 14 days time on an average. Now, if it lives for a short period of time, it is unlikely to mutate so easily unless there is a selection pressure that comes from antivirals or the immune response that our body tends to throw is likely to be responsible for mutations of the virus. There are two possible reasons for which we should be worried. Now, one reason could be we know that there are no specific antivirals against this particular virus. Naturally, it is not drug induced. If it is an immune response which is leading to it, then two possible reasons which we have to consider: repeated use of convalescent plasma, you tend to give them then different neutralizing antibodies which are present in different human beings, and naturally you will find that that selection pressure perhaps is one that may be exerting influence to mutate for this virus, and infection among immunocompromised hosts perhaps may last longer. The virus may be surviving longer, and it provides an opportunity for this virus to mutate. Do we know enough that there are no such mutants? One of the things which we have to remember, that genomic surveillance was started by us in March 2020 itself. In 35 virus research diagnostic labs across, they were expected to share 5 samples every month to try and find out whether such mutations are occurring, because there was not much of an evidence then. The virus was known to mutate, mutation rate of this virus was always thought to be little lower than rest of the viruses that we are more familiar with. But now what has happened is there is an expanded genomic surveillance, and NCDC, the National Center for Disease Control, is leading this particular effort. Now, can we say based on this, since very few mutants or mutants of significance have been reported, we cannot say that there are no significant mutations that are occurring in the country? The reason is very simple. There is a very large caseload, and what we test is a minuscule of those samples. Naturally, there would be a large uncertainty when we say that there are no mutations in India itself. Some early evidences that emerge suggest that these escape mutants may escape immune response from certain vaccines. Now, the next question that tends to come, is that going to be a big threat for us? But you look at the graphs now. Now you look at UK. Now, what is our fortune? In UK, the outbreak is on a decline. We know that these mutations were detected sometime in September. The air traffic was also on, but so far, so many samples have been tested for genomic surveillance, but the number of samples that were found to have this UK variant, it continues to remain a minuscule fraction. And since it's a minuscule fraction, and you find that the curve is declining, perhaps that threat doesn't appear to be creating a major problem as a imported infection. When it comes to South Africa, South African strain is one of the dreaded ones, because it is likely that based on whatever evidence that we have so far, vaccines either may not protect, some of them may not protect, and also those who which may protect may have lesser efficiency or lesser efficacy for protection itself. So, but the redeeming feature is South African wave also is on a decline. So the likelihood that it will be imported is also going to be less and lesser as the time passes by. You look at Brazil. Brazil is a worry. Brazil's outbreak continues to be higher compared to those which are high burden countries as such. But there is one thing which we must remember, that the traffic between Brazil and India is far lesser and far rarer compared to rest of the international travel. But we do not know whether Brazil to US travel, US, the infection that could be imported into US is likely to pose a threat to us. We have still no idea, but this is something which is perhaps a plus point against which we need to think about it. So essentially, what does it tell you? If you look at the comparative chart, since these majority of these countries may show a decline or are unlikely to affect us, we are still in a better position compared to what is being witnessed elsewhere. One of the good steps that the country has taken is we have issued international travel related guidelines, and they were made more stringent of recent. So far, the number of mutants that have been observed continues to remain small. It remains less than 200 even today. Their isolation and contact tracing is given a primacy, and that is being done very strongly. There is no epidemiologic suspicion so far, though this is a very crude measure to assume that mutants are likely to be found there. We can still prevent and restrict the entry of these particular variants within the country. Will these measures ensure that the variants will not challenge us? You cannot say that with certainty. The more the number of cases that occur in a given geographic setup, you will find more replication of this virus will occur. The virus will also perhaps have a different selection pressure that comes from different individuals per se, because of the spectrum of neutralizing antibodies that each individual can produce. And naturally, since the virus keeps on replicating in one or the other body, you will find that the virus is more likely to mutate given the numbers increase as a background. Please ensure that we avoid use of convalescent plasma as much as possible, and definitely not a repeated convalescent plasma to be used among individuals. The bigger challenge that we have today is sustaining or adhering COVID appropriate behavior. If you look at IHME data of mask use, you find that the reported mask use has dropped from 71% to 64% as of now. 71% was at the beginning in March and April of 2020, and currently it is close to about 64%. You look at the mobility patterns. No, mobility is also gauged by them through the mobile's mobility, the location that is tracked. And you look at the observed reduced mobility. Now it has come from minus 42% to close to minus 23%, which essentially means that in this particular period, close to 20% of higher mobility has been observed across in India. Lockdown lifting is entering into a crucial phase of opening, especially schools and colleges. And naturally, it is likely to create a problem because this population had not been exposed to this particular virus as much because this particular educational institutions were closed for a long period of time, or they were teaching through online methods as such. So what do we do in given these circumstances? We need to recognize that one jacket does not fit all, especially when you are lifting lockdown. So you would have different interventions that are there, which includes lockdown, which includes containment, which includes closure of schools if there is a smaller outbreak that tends to occur locally in that particular school. So we need to consider that you need to have differences. There are differences in the levels of outbreak in smaller geographic areas. Additionally, the size of social networks, like you must have had heard, no, of recent, Vidarbha is showing a probably a resurgence in that particular region, despite the fact that the population density is not high in those areas. No, the size of social networks, adherence to COVID appropriate behavior, and quality of implementations of the strategies tends to be different. And therefore, one of the things which we have to consider that we should not treat a particular date as sacrosanct and then implement it across in the entire state or a country. We need to have a decentralized approach. Now, what do we mean by decentralized approach? Whatever strategy you choose to prevent the emergence of the second wave, you need to ensure that that decision should be taken by the local administration. You need to monitor opening of schools and colleges. We may need to have a surveillance approach to determine whether the school requires a closure or the schools in that region require a closure temporarily as such. And that's something which to my mind is critical. If we don't do that, then the spread of outbreak is likely and it may eventually lead to endemicity. We need to promote COVID appropriate behavior strongly among migrants. This disease is more likely to become endemic. Rigorous adherence to COVID appropriate behavior, irrespective of vaccination status, is vital, and that's a message that we will have to keep on passing. Most importantly, what we need to do is the entire world, when it is going to go into a declining mode, we must make all out efforts now. The strategy will continue to be based on test, trace, isolate, and treat. And additionally, you would have a weapon of vaccines that may come. Vaccines is one area which has an association with the level of perceptions of risk that each individual would have. If you look at what is vaccine eagerness across in the world, you find that areas where the infection currently is on the rise, you find that people are more eager to receive the vaccine. As the risk tends to go down, perception tends to go down, people tend to land up into vaccine hesitancy. Now, if it is vaccine hesitancy, we need to find out what are the reasons. And in one of the studies, what they found was most of the people are worried about side effects, though in India also we are finding that the numbers are not so high. Serious side effects don't occur, but then we need to convince people about it. Looking at the rates which we are observing as of now, people tend to believe the vaccine trials have taken place very rapidly, and therefore there is a fear that are these vaccines good in quotes. But we need to remember that we could do this very quickly because of experience in HIV, where the vaccines have actually failed. People tried different vaccine platforms for development of vaccine against HIV, and those were further refined when it came to Ebola. You find that the same vaccine development platforms were used to develop vaccine, and that's the reason why it could happen very quickly. So you should not worry about whether the rapid development of vaccine is indicative of poor quality of vaccine as such. The data of clinical trials is perhaps something which we have to reflect upon. Now, some people believe the vaccine may not be effective. Largely, you will find that this tends to occur because people have a perception that even if I don't take vaccine, I'm unlikely to acquire COVID infection. The sole reason is the declining wave asset. And a small proportion of people continue to be anti-vaccines. They belong to anti-vaccine lobby, and that's the reason why vaccine hesitancy tends to be there. One of the things which we have to realize is, though we knew how is the evolution of vaccine programs, there is a classical stage where people tend to present with vaccine hesitancy, the coverage tends to increase, and then in between there is loss of confidence, where even social media tends to play a lot of role, or media in itself can play an important role. You find that after a period there is resumption of confidence, and then the vaccination coverage tends to increase and the disease is eliminated to a larger extent. We forgot that even in H1N1 vaccine, when the results were available within 6 months of development of vaccine, this vaccine was provided free by government of Maharashtra in India. You find that most of those who were expected to receive this vaccine, if you look at their coverage rates, they are extremely poor. They are between 1 to 2% of the entire size of these groups. And naturally, this is one experience which we should not have forgotten, that people tend to question the efficacy of these vaccines and tend to get worried with that. If you look at the current status of vaccine rollout, what is it that you find? We are at the fourth rank in the world so far, but we should not feel very happy with being fourth. The reason is we have a very large population size. Countries would be able to offer this vaccine just because of smaller size to large number of people in their own countries and develop herd immunity. If you actually look at the time that perhaps we can project and see when we would vaccinate 75% of people, you will find USA and UK would probably be covered altogether, would have a good herd immunity by September 21. Now, which essentially means that in 6 months' time, they would have had made 9 months' time, they would have had made a major difference and protection will ensue. But look at the other countries. If we continue to vaccinate at this particular rate, we and Brazil, we and Russia would probably complete our first vaccine requirement in 10 years' time, which is not a good thing to happen. We may have to use different strategies, including public-private partnership, to try and ensure that we roll out these vaccines effectively. China would require 3.6 years. Brazil would require 3.5 years. But what is more still difficult to understand, you look at Canada, which had actually done advance booking for 5 doses of vaccine per capita. Unfortunate part is they would still require close to about 6 years time, given the rate at which they are vaccinating. The sole reason behind this is vaccine nationalism. People tend to see that they would vaccinate, country of origin of these vaccines would vaccinate their own people first and then allow that to be given to others, despite the fact that advance booking has already been done. The implication of development of rapidly transmitted variants essentially is one pointer that we should reflect on rapid rollout of vaccines as such. Initially, it was between 58 to 74% when people thought that these kinds of variants or antigenic shift may perhaps not occur in this particular infection. But now that you are detecting more and more mutations in the virus, which is definitely trying to mutate, there is a room to think that development of mutants, which may develop escape mutants against these particular vaccine-induced immune responses, is an imminent possibility. Therefore, if we want to protect our population, now herd immunity may not kick in at between 58 to 74%, but it may kick in when the herd immunity is over 90%, which requires a rapid scale up through vaccine coverage. So essentially, what does it mean? Vaccine acceptance is vital. We need to cover people with these vaccines rapidly. What needs to be strengthened furthermore is community mobilization. We need to develop group specific communication. The best flavor that we had seen is in HIV. The communication messages that used to go to adolescents were far different than the messages that used to go and the manner in which they were packaged for other adults, no, for pregnant women. Those messages were different. And that's the reason we could make a huge difference even in the other pandemic of HIV. But we need to ensure that these group specific communications, peer based approaches for information and adherence, they need to be tweaked. Involve key opinion leaders in different strata. Currently, what is happening is people tend to believe that one leader or two leaders in a state or in the center, if they receive the vaccine, perhaps, or if they communicate on behaviors, the entire community will change. We must remember that each one of us has a limited circle of social influence, and therefore everybody has to look forward to a group specific or a strata specific key opinion leader, and then we can ensure that the adherence to these behaviors will happen. There is a room to develop an ideal demonstration field site where complete package of intervention, including vaccines, is rolled out so that people can learn from such projects. Finally, the emergence of second wave in India is preventable. We need to recognize that maintaining health of people is not only government's responsibility, but is also that of individuals and communities. One can only remain safe if others with whom he or she can be exposed as well are also safer. In the modern era of high mobility, our safety also depends on safety of others, however distant they may be staying, even they may be staying in other countries. And that's the reason why you find India is also adopting a strategy of providing free vaccines or providing vaccines to other countries around in the region so that we remain protected. I will stop here. Thank you.
Thank you, Dr. Gangadhar. It was indeed a fantastic lecture. I think if this recording is going to be available, then we'll have to listen to it once more to understand many of the subtle points which you made. It was a marvelous analysis, and I'm sure we will have lots of questions, and you'll be able to take them. And with this, it's my great pleasure to introduce Dr. Sanjay Pujari, again, a very eminent speaker, and his CV is flashed here, and he's the Director and Chief Consultant at the Institute of Infectious Diseases at Pune. Postgraduate in internal medicine, he's been involved in HIV research and training for the last 25 years, and he has been a principal investigator for Treat Asia, and the START study has been involved in training physicians globally, including faculty at the European AIDS Clinical Society's HIV Advanced course. He has published and presented numerous papers with focus on ART and is the member of the ICMR National Task Force on COVID-19. And what his CV is not really telling you, but I will tell you, is that he is a real thinker. His capability of analysis, the clear thinking, and adapting whatever comes out of guidelines for the conditions where we are practicing, that is for our Indian patients in different settings, is amazing. And I always look forward to hearing from him. It's always new, even if the topic is the same. So with this, I welcome Sanjay, and please start your screen share.
Okay, thank you, Rajiv, for the introduction, and again, thanks Hetero as well for this opportunity. We, in our lifetimes, have gone through two big pandemics. One is HIV, and of course, now is the COVID-19 pandemic. And in that sense, it's not surprising that these pandemics will be intersecting with each other. And then you would really need to have research trying to understand what are the interactions amongst these two different pandemics. So this is the outline of my presentation. Give you thought on what is the impact of HIV infection on COVID-19. Then we will look at the impact of COVID-19 on HIV. And finally, I think it's very important for us to, as people have gone through the HIV pandemic, to learn lessons from the HIV pandemic and how we can apply them to try to control the COVID-19 pandemic. A disclaimer at this point of time, this is a very rapidly emerging field. Information is quite preliminary, and most of the just a moment. Is my slides visible or?
No, doctor.
Just a moment. Okay, is it visible now? Yeah, so
No, doctor.
is it not visible still?
Still not visible, doctor.
Because it's saying it is already scaring your screen sharing.
No, there seems to be some problem, sir. The slides are not visible.
Okay, let me again do it. Now?
Not visible, sir.
Yeah, okay. So sorry for the problem here. So the first thing, of course, is whether HIV increases susceptibility to acquire the COVID-2 virus. And there is not much data on this, but this is one of the studies which looked at attack rates in individuals who are HIV positive, both crude and corrected attack rates. In individuals who are HIV positive on ART, individuals who are taking pre-exposure prophylaxis, and the general population. And the conclusion really is that there is no evidence that HIV per se increases the susceptibility to acquire COVID-2 virus because it's assumed that immunodeficiency, the risk of infections are higher. These are technically what we used to call as opportunistic infection, but looks like CoV-2 is not an opportunistic infection, just like many other infections which may occur in the HIV do not occur at a higher rate than the general population. The second aspect is, of course, severity of COVID-19 in individuals who are HIV infected. And as the epidemic has evolved, studies have also evolved, and very early reports really came from the developed world like US and Europe. And what essentially they showed was there was no difference in the severity of COVID-19 illness as compared to HIV negative population. But these were very early case series. They were underpowered, not many patients, no good comparative groups. And predominantly the population which was HIV positive were young in this context. So these are some of the large population-based studies which are recently published, which are looking at the impact of HIV infection on COVID-19 severity. And this is one data from the primary care settings in the UK, where they demonstrated a higher probability of cumulative probability of mortality is a little higher in HIV positive individuals as compared to HIV negative. And this is interesting, but of course there are problems with this, and that is the absolute mortality, as you see, is very low. It's almost less than 1%. And most of the individuals who died in this study who were HIV positive had actually a lot of comorbidities. So this study needs to be taken with a pinch of salt. And this is the risk factors in this study. Obviously, age is an important risk factor, being male is an important risk factor, as well as the presence of more than one comorbidities, more than or equal to one comorbidities are important risk factors for COVID-19 severity amongst HIV infected individuals. So HIV per se is not really in these studies causing a higher risk of COVID-19 illness. This is another study again from the UK amongst hospitalized patients. In patients who are hospitalized with COVID-19, differentiated according to whether they are positive or negative. You can see here they are predominantly young individuals as compared to HIV negative, who predominantly are older individuals. So young HIV positive, but even in young, in that sense, it's more than 50 years is the median age. And when they looked at 28-day mortality, actually there was no difference between HIV positive and HIV negative individuals as far as COVID-19 mortality was concerned. But when you stratified according to age, what they found was at the age of more than 60 years, there was really no difference in mortality. But when it's less than 60 years, age 50 to 59 or less than 50 years, the mortality amongst HIV infected individuals with COVID-19 is higher than the HIV negative population. So age younger, you may have a higher mortality due to COVID-19 amongst HIV infected individuals who are not elderly, who may be less than 60 years. Again, when they looked at risk factors, you see age is an important risk factor, as well as presence of comorbidity like diabetes, obesity. And any receipt of ART in the past actually was associated with a lower regard of COVID-19 associated mortality, suggesting that ART may be protective for COVID-19 mortality. But this is again very preliminary and controversial. This is data from the US. Again, it shows here, it's a large database looking at standardized rate ratio as compared to HIV negative population. And whether you look at the proportion of HIV positive who are diagnosed with COVID-19 or hospitalized or in hospital death, all of this is a little higher rate ratio as compared to HIV negative population. So here in the US, it looks like HIV positive individuals may have a little higher mortality than HIV negative. And this was for the first study to really show that HIV stage is almost linearly correlated with mortality. Advanced HIV stage is associated with a higher standardized relative risk as compared to stage 1 and stage 2 disease. So looks like if you have an advanced immunosuppression, you may have a higher risk of COVID-19 illness and mortality associated with that. So then, what is the role of CD4 counts? Do CD4 counts protect you from severe COVID-19 illness? This is a study again from the UK, and whether you look at mortality or morbidity, and whether you're looking at current or the lowest CD4 count recorded for that individuals. So the mortality was lower in individuals who had a higher current CD4 count or a higher nadir CD4 count as compared to individuals who died. As well as severe illness was more common in individuals with lower current CD4 count, as well as lower nadir CD4 count compared to individuals at a higher CD4 count who tend to have predominantly mild to moderate illness. And this is another survival stratified according to CD4 less than 200, 200 to 500 and more than 500. And overall survival or ICU-free survival was associated with CD4 counts with higher mortality when the CD4 is less than 200 as compared to 200 to 500 and more than 500. So low CD4 count may be a risk factor for severe COVID-19 illness amongst HIV positive patients. This is the last study. I'm sorry for I couldn't get a good picture of this, but this is from the South Africa. Again, it's a population-based study where they looked at various factors, and what the summary of this slide is that HIV positive individuals have a higher hazard of mortality associated with COVID-19, and they also found history of tuberculosis, or current tuberculosis also being associated higher mortality secondary to COVID-19. But here, of course, there are a lot of caveats in this study. Almost only 50% of these individuals were on antiretroviral treatment. Maybe CD4 counts were low. So this is essentially telling you that perhaps maybe in high endemic HIV situations, HIV may significantly contribute, particularly if you're not on ART and if you are unsuppressed, to higher COVID-19 related mortality. And finally, this is a meta-analysis which recently published, which looks at all these studies together, which are by and large good studies according to the authors. And the conclusion is that HIV is associated with almost 2 times higher hazard risk for mortality amongst due to COVID-19 as compared to HIV negative individuals. Now, whether this is adjusted to comorbidities, age, gender, and all those things is something which needs to be further analyzed. So do we have India? This is a preliminary data which is unpublished, which is in review in a journal where we looked at COVID-19 amongst HIV infected individuals coming to our clinic. And as you see here, this was a sample size of 84 patients. Majority had asymptomatic and mild illness. Severe illness was present in about 12% individuals, 13% individuals. Most of them were managed in the home settings. Significant proportion of hospitalized, but this was prior, very early in the epidemic. Patients were admitted even if they had mild infection into hospitals for isolation purposes. So majority, what you really see is mild illness, which is quite common amongst HIV infected individuals in a population. Of course, this is a very small sample of patients in the study. We also found a fatality ratio of around 7%. Again, this is a very preliminary, the denominator is less. But if you compare it with some non-HIV cohorts, it's is reported between 2 to 4%. There are 95% confidence intervals reported in the studies, but looks like a little higher mortality. HIV infected individuals who are having COVID-19 in India, and on meta-analysis, on multivariate analysis, we found only comorbidity and not the CD4 count, not the viral load associated with higher risk of mortality, almost an adjusted odds ratio of 4. These are common COVID-19 symptoms. These are not different from HIV positive. You see, predominantly people have fever, cough, dyspnea, fatigue, myalgia, and a small proportion have anosmia, ageusia, sore throat, and diarrhea. So the symptomatic presentation is not really much different. This is another small case control study which we did, which is also under review, where we looked at HIV positive with COVID and HIV positive without COVID, and looking at what are the risk factors for a diagnosis of COVID-19. So essentially, we looked at many of these factors, but the interesting aspect was individuals who were on a TDF-based regimen had lower odds of being diagnosed with COVID-19. Now, this is quite provocative because there are some evidences from Spanish study and also the South African study, which showed that perhaps TDF-based regimen is associated with the lower odds. We'll talk about it when we come to use of ART in the COVID situation. So changing gears, we now look at what is the issues with diagnosis and management of COVID in people living with HIV. And as it's simply, there is no difference in diagnosing or managing as compared to HIV negative population. There is some interesting, very early preliminary case reports looking at some of the serological issues. And one case report with 2 patients, with 5 patients actually, from Japan shows that the seroconversion for SARS-CoV-2 is similar for people living with HIV as compared to HIV negative. So they tested for various antibodies, and the time for appearance of these antibodies, as well as the proportion of patients with developing antibodies was similar. So it doesn't look like serological response to CoV-2 should be different amongst people living with HIV. An interesting two-patient case report looking at cross-reactivity of SARS-CoV-2 with the diagnostic rapid HIV chemiluminescent assay from Abbott, where they found two patients having false positive HIV reports. So this is something which is important. So when we are really seeing patients in our practice and patients coming to us with rapid ELISAs or rapid test reports positive after a SARS-CoV-2 infection, you may need to really go through the algorithm very rigidly for diagnosis of HIV infection. The second aspect, which is very important when HIV positive patient comes to you, is factor in opportunistic infections in the differential diagnosis. And this is a summary for and COVID-19 amongst infected individuals. You see, there are people who have PCP being misdiagnosed as COVID. There are people whose COVID is misdiagnosed as PCP. And there are some case reports of both happening together. COVID-19 as well as PCP co-infection. So don't forget opportunistic infections, because many of these HIV patients actually may have stopped their ARTs because of lockdown, access to treatment issues, and they come back to you with symptoms similar to COVID-19, and then you are working up only for COVID-19, but don't forget opportunistic infections. This is a case report which we published recently, where actually we could demonstrate that HIV patient coming to us with COVID-19 symptoms had similar radiological features like COVID-19, as well as inflammatory markers suggestive of, which are high as in COVID-19, actually turning out to be tuberculosis. And the BAL for SARS PCR was actually negative. So don't forget opportunistic infections while you are working up individuals for COVID-19. The third important aspect is what happens to these inflammatory markers. We have been following inflammatory markers in the HIV, in the non-HIV situation, like D-dimer, CRP, ferritin, etc. That itself is an inflammatory state, and it's also age dependent. This is a very old study which said CRP, IL-6 levels, D-dimer. And is the percentage difference between HIV positive and HIV negative. And as you see here, these markers are as it is high in HIV infected individuals as compared to HIV positive individuals as compared to HIV negative. And this is also true even if you are younger, the percentage difference for HSCRP and IL-6. So HIV is an inflammatory state, and you're going to have high levels of these markers. Whether that impacts COVID-19 situation, we don't have data for the paper which looks at in COVID-19 with in patients who are HIV, what is the trajectory of inflammatory markers. And certainly what you see here is HIV negative and HIV positive who are virologically stressed. Yeah, they saw lower inflammatory markers, and the same was true for ferritin as well. Also saw the same thing with IL-6, HIV positive unsuppressed having IL-6 level compared to HIV positive suppressed, and same thing with neutrophils as well. What is the role of ART, particularly its impact on COVID-19 and DDIs? We now know that ritonavir doesn't work for COVID-19. The 3 randomized controlled trials, including solidarity and recovery, which don't show a benefit for use of lopinavir. I'm sorry for this, I don't know. was lower with TDF-FTC. Now, it may be a channeling bias because patients on TDF are less likely to have comorbidities like chronic renal disease. But this is something which is interesting. There are trials now going on to look at use of TDF for both prophylaxis and treatment of COVID-19. We also should not forget in the HIV field drug-drug interactions. And in this situation, ARVs with remdesivir, you can see no interaction. As far as dexamethasone is concerned, there is an interaction with ritonavir and PIs. So you have to be very careful when you use this because you can have higher levels of steroids when you use concomitantly with the PIs. And heparin, of course, there is no interaction expected. Finally, we talk about long COVID, and long COVID is something which is still not very clearly defined, but these lingering symptoms of COVID-19, including some radiological or functional issues, usually persisting for more than 4 weeks. So there is no standardized definition. There's not much data about long COVID in HIV positive individuals, whether they have similar prevalence as compared to HIV negative. This is again a study which we have done, again under review. We saw a prevalence of around 44% of long COVID, and these were various symptoms that we saw in our individuals on a screening questionnaire, right from generalized symptoms like fatigue, myalgia, to neuropsychiatric problems, to respiratory problems like cough and shortness of breath. So this is a significant problem, and we need to really watch for these things in our own practices when our patients come follow up. And when we looked at risk factors for long COVID in population, we saw patients who had history of moderate to severe COVID-19 illness had a higher risk of developing a long COVID as compared to patients who had mild to or asymptomatic infections. So that is something which is interesting. Of course, these are very preliminary data, and we need to really take it with a pinch of salt. Other issues like duration of isolation. This is one case report which shows that in an advanced HIV infected individual, the virus was positive even in culture up to 91 days with COVID. So there may be a prolonged viral chain. Very advanced HIV disease, particularly in individuals who are CD4 less than 200, a symptom-based strategy to stop isolation may not suffice. You should perhaps be looking at a test-based strategy of using RT-PCR negativity for stop. And finally, vaccine. At this point of time, we know the low number of people with HIV participated in vaccine trials. In the Oxford vaccine trial in UK and South Africa, around 160 HIV positive patients were covered. But the data analysis not done. To be safe as no it's not a live virus. As is known with some other vaccines in HIV context, there may be a potential reduced effectiveness due to suppression, particularly when the CD4 is less than 200. At this time, I don't see any guidelines not recommending a COVID-19 patient for HIV infected individuals. In fact, most guidelines recommend, and many of them really recommend it to be a priority group. So at this point of time, we are advising our HIV positive patients to maybe go ahead for vaccine when it is available. The other issue is just a slide on the impact of COVID on HIV. The most important impact is not only in terms of progression of disease or things like that, but because of disruption in HIV care, many patients may have soft ART. They may come with AIDS-defining conditions. This is already happening in the UK. Their admissions severe AIDS-defining conditions, the non-AIDS-defining conditions in the previous year. There is delay in testing for monitoring and toxicity and response, thus because people can't access. There may be ART. This may be a setback to progress towards UNAIDS 1990. Both pandemics were very urgent, so we respond rapidly developed treatments for. So essentially, HIV set a benchmark which was followed by the COVID-19 community as well. We also know that transmission is mostly behavioral. Risk communication and community engagement, which Ganga mentioned, is key for prevention. And social networks, again, Ganga mentioned this, and opinion leaders be put in, need to be used to get our messages across. Perhaps it's also important for in the HIV context, we use some legal instruments to protect rights of HIV positive patients. There is some discrimination, though now it has gone down for COVID-19 patients. It's important to use legal instruments. Surveillance in HIV was key for policy and strategy development, and it is key also now for the COVID-19 pandemic. We know that most of the platforms that are using COVID-19, like the RNA adenovirus vector, are actually platforms which have been tested for HIV vaccine. So the accelerated vaccine development, as Ganga mentioned, has been with these platforms which have already been tested, though they didn't succeed for as far as efficacy was concerned in the HIV context, but we are glad that these platforms are being useful in the COVID-19 context. Intersectoral collaboration, including data sharing, which we saw in HIV, where people were more open to share data in research, is also happening in the COVID-19, and that's an important aspect of developing a response. Involvement of society, which we did in HIV, is also important from the COVID-19 perspective. As Ganga mentioned, it's not just the government which is responsible for maintaining health, but every individual has its own responsibility for health. And finally, HIV led the way for generic manufacturing of medications. We know all our ARVs have been wonderful markers or tools which we have used to prolong the lives of our HIV patients. And this was thanks to the generic manufacturers, and they are now following it up with, say, drugs like remdesivir, which is also now being generically manufactured. So these are all examples from the HIV epidemic, which translates into lessons for the COVID-19. Let me summarize by saying that at present, the understanding of the HIV impact on COVID-19 illness is very preliminary. There's more data needed to understand this impact. At this point of time, it's very clear, at least, that comorbidities, obesity are very strong driver of COVID-19 outcomes, even in HIV positive individuals. As our patients who are HIV positive are aging, they are developing comorbidities. I think they are also as vulnerable as the HIV negative population to develop severe outcomes. ART appears to play a very little role in COVID-19 outcomes. We really don't know. We need more data on that. And finally, I think vaccines, most guidelines do recommend COVID-19 vaccines for people living with HIV as a priority group. And I think I'll end there and we're happy to take questions later.
Thank you, Sanjay. Another wonderful lecture, quite thought-provoking. These are early days, and we really need to understand much more about the interaction when the two viruses run into each other, what's really going to happen, and how we can manage it. And with this, it's my pleasure to introduce Dr. Atul Patel from Ahmedabad. Again, a very well-known personality in this field of infectious diseases, HIV, invasive fungal infections, and so on. So naturally, the topic that he's going to address is COVID-19 and invasive fungal infections. He's the Chief Consultant and Director of ID at Vedanta Institute, Director of Department of ID at Sterling Hospital, Ahmedabad, also the visiting Associate Professor of Medicine, Division of ID at Tampa, Florida. Founding member of Asia Fungal Working Group and Fungal Infection Study Forum, and he's authored current global guideline on mucormycosis, which got published in Lancet ID, and currently is conducting a multi-center study on mucormycosis in COVID-19 patients in India. It is under the aegis of FISF again. With this, I request Atul to start his presentation.
Yes, thank you, Rajiv. And let me thank Hetero also for providing this opportunity to speak on the fungal infections in COVID-19. Let me start my presentation. Yes. So I hope my slide is visible to everyone. Yeah. So my topic is invasive fungal infections in COVID-19. These are my financial disclosures. Research speaker honorarium from and advisory board meeting from Pfizer, Mylan, Cipla, Intas. In this talk, I'm going to cover two important mold infections that is predominantly seen in COVID-19 patients. One is Aspergillus and second is mucormycosis. So let me start with the Aspergillus infection first. So with the beginning of COVID-19, like we had apprehension and fear that like influenza, we are going to have a large number of invasive Aspergillus infections with this SARS-CoV-2 infection, that is COVID-19 disease. But what we found, like from the publication that we had since last over a period of 1 year, that COVID-19 probably may not be a direct risk factors for invasive pulmonary aspergillosis, though researchers has pointed out lymphopenia as one of the risk factors, and the disturbance and dysregulated immune system leading to some damage to the innate immune system, probably which may influence the occurrence of invasive mold infections. But largely the invasive pulmonary aspergillosis or IPA is largely related to the risk factors which is probably involved with the treatment and the care of the COVID-19 patients, that is steroid use, tocilizumab, the invasive ventilator, and the broad spectrum antibiotics, apart from the other host factors with the COVID-19. So largely it is related to the treatment of the COVID-19 pneumonia. And the published studies so far, which says that the kappa or the COVID-associated pulmonary aspergillosis occurs in almost 20 to 30% of severely ill patients. So these are the ICU admitted patients or the mechanically ventilated patients. And other studies which says that it occurs around 40 to 20%. So the incidence of kappa or the COVID-associated pulmonary aspergillosis is little higher, and it is associated with a very high mortality. So don't try to read all these things. The figure is from the Emerging Infectious Disease published in January 2021, just to emphasize you on the burden of kappa or the COVID-associated pulmonary aspergillosis globally. So with the beginning of COVID outbreak in January, February 2020, like we have few evidence of Aspergillus infections in COVID infected patients from China, obviously, because the outbreak was started in China. But later on, as the outbreak spreads to the rest of the world, we are getting more and more informations on the kappa from the France, Germany, Netherlands, Austria, Belgium, China, Europe, Brazil, Pakistan, Italy, Switzerland, almost every countries, including Denmark, UK, and the US. So now the kappa or the invasive pulmonary aspergillosis has been reported from across the globe in the COVID infected patients. So looking at this large burden of the kappa burden, the ECMM and the ISHAM, they try to bring out the consensus definitions. How we are going to define the invasive pulmonary aspergillosis in COVID infected patients? So they bring out some definition, working definitions, and the important difference of these definitions from the influenza associated pulmonary aspergillosis is that they have also included a possible one. So we'll see like what is possible, what is proven, and what is probable. So proven is very easy for every one of us. So for us clinician, like when we are looking at the presence of fungi into the tissue on histopathological examination. So when we are looking at mycelia into the tissue with surrounding inflammations and the evidence of tissue damage on histopathological examination, I think that is excellent evidence that somebody is having invasive pulmonary aspergillosis. You can also have a confirmed or the proven invasive aspergillosis when you are demonstrating presence of mycelia in on a direct microscopic examination of a tissue, right? So when you are looking at a biopsy, performing a direct microscopic examination with either the KOH or with the calcophrol white, and if you can demonstrate the presence of hyphal structure, which is consistent with the aspergillus, then probably that is a confirmed or the proven kappa or the COVID-associated pulmonary aspergillosis. But you know that, like, I mean, the performing bronchoscopy and the transbronchial biopsy is very difficult because of the reasons of it is the aerosol generating procedures, and because of the bad lung or the damage or the inflamed lung, like biopsy is not possible, because even the smallest air leak can give you significant hypoxemia and patient may desaturate. So the invasive procedures like bronchoscopy, because of the fear of the aerosol generations, and the biopsy because of the lung damage, may not be possible. So we clinician will have to heavily rely on a definitions of probable kappa or the probable COVID-associated pulmonary aspergillosis. And how we are going to define this probable kappa? Obviously, like in appropriate clinical settings, when you have a CT scan features or the mycological features. So what are those radiological and what are those mycological features that we'll see? So to reach a diagnosis of probable kappa, we need a CT scan features. Though because of the extensive COVID, extensive ground glassings, and later on reticulations and the fibrotic changes, like you may not be able to appreciate the classical described features of the invasive pulmonary aspergillosis. But this is what, like, the clinicians are looking at the radiological features. One is the presence of pulmonary nodules, the cavitary pulmonary nodules, or the pulmonary cavities. So what are those radiological features? Again, I'm taking a help from the same publications from Emerging Infectious Disease. And this is what they have shown, that this is in A, this is a cavitary pulmonary nodule. In the B, this is a dense nodule. Again, in E, it is a cavitary pulmonary nodule. So this is how, like, you can, when you are looking at nodules or cavitary pulmonary nodules in a patient who is terribly sick in ICU with a COVID infection, then you should do an appropriate workup to find out, to make a diagnosis of probable aspergillosis. Apart from these nodules, cavities, and cavitary nodules, you can also look at the thickened bronchial, the wall. Here you can see that there is a thickening of bronchial. So tracheobronchitis can be seen with the COVID-associated pulmonary aspergillosis to a lesser frequency compared to the influenza-associated invasive pulmonary aspergillosis. So these are the few of the radiological features. So none of the radiological features is diagnostic of kappa, but we have to do appropriate workup whenever we are looking at the nodules or the cavitations within the nodules, that these patients can have the invasive mycelial infections or the pulmonary aspergillosis, right? So these CT features are not diagnostic, but it will tell you that you need further workup to rule out invasive fungal infections. Now, apart from the radiological features, the mycological evidence is again very important, because that will support your diagnosis of kappa. So I already told you that the pulmonary tissue culture or the direct microscopy probably will give you a direct evidence to confirm a diagnosis of kappa. But you can also look at the BAL sample. That the aspergillus can be colonized into the tracheobronchial tree of any other individuals, right? So demonstrations of aspergillus into a BAL probably is not a good evidence that patient is having invasive the pulmonary aspergillosis. But when you have an appropriate clinical settings, appropriate radiological features, demonstration of this aspergillus into the BAL sample, not into the tissue. Tissue will confirm a diagnosis, but in BAL probably will help you to support that you are probably dealing with some invasive fungal infections. The another important mycological evidence that you can get from your patient would be the BAL galactomannan or the BAL galactomannan. So when you are using a galactomannan to make a diagnosis of invasive pulmonary aspergillosis, when you use a cutoff of 1, it has got a sensitivity of 83% and specificity of 87%. But when you increase the cutoff to 1.5 index, then the specificity jumps to 90%. So when you are using a BAL galactomannan with good cutoff, probably it will give you the good informations about the pulmonary aspergillosis. But we have to remember that the BAL galactomannan positive does not tell you that this patient is having invasive pulmonary aspergillosis. It may literally tell you that there is a replicating fungus, but it may not have invaded the tissue, right? Again, for real invasive pulmonary aspergillosis, you need a tissue to demonstrate invasions of hyphal structure. The another important test which is evolving and probably coming to the Indian market soon would be the lateral flow assay. This is just like any other lateral flow that we use for making a diagnosis of, say, for example, cryptococcal meningitis or cryptococcal disease. Similarly, this the lateral flow assay for aspergillus is also works from the blood or the serum as well as from the BAL sample, and it has got a very good sensitivity and specificity. And under the banner of FISF, we are going to, compare the lateral flow assay with the galactomenon in coming months. So we are starting this study to see the sensitivity and specificity of lateral flow assay in Indian patients. The another important fungal biomarker would be beta-D-glucan. So we know that like beta-D-glucan is, the candida is very rich in this beta-D-glucan, but it is also seen in the aspergillus. So though it is not specific for aspergillus, because except mucorale and the cryptococci, most of the fungi, either it is a dimorphic fungi or it is the mycelia or it's a yeast, can have little bit of elevations of beta-D-glucan because of the invasive infections. So it is not specific for aspergillus, but when you demonstrate 2 consecutive positive results, probably it will generate a good amount of specificity for making a diagnosis of invasive aspergillosis, right? And again, another important test which can help you in arriving a diagnosis of the aspergillus PCR, which is currently not available into the Indian market. Now, taking to this kappa, like why I'm quoting this study, because this is probably, I think, very important and interesting study conducted into Italy. What they did, it is one of the, it is a multi-center study, and they have enrolled all intubated patients into their ICU, and all patients enrolled into this study, they underwent a screening protocol for IPA. So all the patients were positively screened for the presence or absence of invasive pulmonary aspergillosis on admission as well as on day 7 if patient has clinical deterioration. So at least 2 times, at least 1 time, and if required 2 times, they have been undergone the evaluation for invasive pulmonary aspergillosis. So total they have enrolled 108 patients, and out of these 108, almost 28% of the patients, they have probable kappa diagnosis. So they positively looked for the presence of invasive pulmonary aspergillosis in all patients, and they could pick up 28% of the hospitalized patient had kappa. And the median time of making a diagnosis of kappa was 4 days after ICU admission. So it's so early, like in this Italian cohort group. And what they additionally found that the giving a voriconazole for these kappa patients, out of 30 patients, 13 patients voriconazole, 43% of the patients they received voriconazole, and though it is not statistically significant, but it was associated with a trend towards lower mortality, right? So the mortality is not significantly low, but it is showing lower mortality. So this is the same study that I'm showing you again. So what they demonstrate that whenever your patient with COVID-19 ICU admitted patients has probable kappa, the chances of survival is poor compared to the kappa negative patients. And if you have a kappa positive patients and if you are offering a voriconazole therapy, it will show the lower mortality rate. So I think like we should attempt to make a diagnosis of kappa in patient who is intubated in ICU and with the diagnosis of COVID-19. But let me tell you that kappa diagnosis is challenging because there are so many issues that we have to face. Let me tell you the real case that we have faced recently. So this is a 64-year male gentleman transferred from another hospital with the COVID-19 bilateral pneumonia, and he is having a chronic kidney disease, and he was on maintenance dialysis since almost 2 years. And when he was shifted to our hospital, he is on BiPAP support. He's running high-grade fever, hypoxic, and tachycardia. And the reason for shifting to our hospital that his RT-PCR now coming to negative. That's why he was shifted to our hospital. He was receiving piperacillin, tazobactam, steroids, and he has also received remdesivir, plasma, and Paxil for his chronic kidney disease as well as for the COVID-19 infection. But the reason for shifting to our hospital was that he was found to have galactomannan index 4.2 in the serum, and the serum beta-glucan was more than 523 picograms. So both these fungal biomarkers were sky high, and this was a CT scan at the time of admission to our hospital showing some thick wall cavitary lesion. And of course, there is still ground glassing in both the lung fields. So with very high galactomannan into the serum, and the beta-glucan was more than upper level of normal. That's why the patient was referred for the evaluation and treatment of fungal infection. So immediately, like, patient requires intubation because of the worsening of the respiratory failure. So patient was intubated, and it has made our job very easy to perform a bronchoscopy. So we perform a BAL on next day of hospitalization. The direct microscopic examination and the culture were negative for any mycelial structure, and the BL galactomannan was 0.2. Right? So this patient was not having any pulmonary aspergillosis, and whatever the serum was showing positive, either beta-glucan or the galactomannan, was related to patient's treatment. That patient was receiving piperacillin tazobactam, patient has received plasma in the packed cells, and as well as the hemodialysis, right? So all these factors can give you a false positive the fungal biomarkers. So this is how, like, we need to be very careful in assessing and putting patients, putting a diagnosis of kappa in our patients. So how do we treat? So first line agents, like, it's a standard aspergillus guideline that we need to provide them either voriconazole, and now isavuconazole is also approved as a first line agents, and it is available in Indian market also. The alternative therapy would be the liposomal amphotericin B in a dose of 3 milligram per kilogram per day. And the liposomal amphotericin is useful when you are suspecting azole resistance. So for European countries, I think liposomal amphotericin B would be a good choice where the azole resistance is little higher. In India, like, we do not have a serious challenge of azole resistance aspergillus infection. So probably we can go ahead with the azole therapy, either vori or the isavuconazole. The duration of therapy, I think it's not clearly defined in COVID-19, but expert panel suggests that it would be around anything between 6 to 12 weeks time. And again, like, you have to follow your patients clinically, radiologically, and if possible, then do a mycological testing. But you have to remember that whenever you are using azole, especially the voriconazole or the posaconazole, you have to do a therapeutic drug monitoring because of the drug-drug interactions and uncertain pharmacokinetics of this voriconazole because of the genetic metabolism. Now coming to the another important the mold infections in the COVID, and that is COVID-associated mucormycosis. So I'm going to discuss the MyCenters data, but before I start talking about the MyCenters data, let me tell you briefly about the fungal infection study for a mucovis study, that is the mucormycosis in COVID. We have collected mucormycosis data from 1st September 2020 to 31st December 2020. So 4 months data from 15 centers across India, and we have 275 patients with mucormycosis during this study period. So to give you more emphasis that this number is much higher, let me tell you the another example that in before 2 years, like, we did the mucormycosis study. Again, it is a multi-center study across India. In that study, we have 12 active participating centers, and that study lasted for 1.5 years. And in 1.5 years, 12 centers, we have 465 patients, right? So in 1.5 years, like, we have only 465 patients, but in 4 months, from 1st September 2020 to 31st December 2020, in 15 centers across India, we have 275 mucormycosis patients. So you can see that the number of mucormycosis that increases because of the COVID, right? So definitely there is a surge in the mucormycosis diagnosis because of COVID-19. So let me take you to our center's experience during the same period time. So during this September to December, like, we have 47 patients of mucormycosis. So in that study, like, we contributed just 29 patients in 1.5 years. And in 4 months time, like, we had 47 patients. So out of these 47 patients, 39 patients were male patients. So it is a predominantly the male were diagnosed to have mucormycosis with COVID, and there were only 8 female patients. The median age is like 60 years, 58 years. So it is the elderly patients. And when we analyze the risk factors for mucormycosis in these COVID patients, like the 14 patients, like they have first time detected diabetes with the diagnosis of COVID. So the COVID has unmasked their diabetes and they develop mucormycosis. So 24 patient has no past history of diabetes out of 47, and 10 has no diabetes even though they have mucormycosis. So this 10 plus 14, like 24 patient, they have no past history of diabetes. So 10 patient has no diabetes and 14 patient first time detected to have diabetes with the diagnosis of COVID infections. The all COVID-19 patients, they have received mucormycosis, received steroids for and developed mucormycosis. And the median dose in my cohort of methylprednisolone was 380 milligram for their COVID illness. Right, so it's a little higher dose of steroids that patient has received for their COVID infections. So out of 47, only 3 patients has received tocilizumab. So probably tocilizumab is not that significant in this small cohort of 47 patients, but let us see, like out of 275, how many of them they have received tocilizumab. 1 patient each had a renal transplant and 1 was having a collagen disease on HCQ and methotrexate. So when we looked at the COVID illness in this mucormycosis patient, so the 35 patients, they have received either ward treatment or they have recovered with the home isolation, right? So they are not that critically ill. They recovered with the ward treatment and the home isolation. Only 8 patients requires ICU care and 4 patients had non-COVID mucormycosis. So they were in the regular hospitals. Out of this 47, only 23 patients required oxygen therapy. So that means that only 23 patients, they genuinely require steroids for their COVID-19 treatment, and rest of the patients, they have received steroids as a part of their treatment protocol. While looking at the mucormycosis characteristics in these COVID-19 patients, the median time to mucormycosis diagnosis from the COVID diagnosis was 14 days. So within 2 weeks of COVID diagnosis, this patient had the new diagnosis, that is mucormycosis. So with the median time was 14 days, the range is 3 days to 56 days. There are few patients whose mucormycosis was diagnosed together with the diagnosis of COVID at some of the centers, right? So it is possible that the COVID is also playing a very important and significant role in precipitations of mucormycosis. The paranasal sinus was the predominant site in this COVID-associated mucormycosis. So 2/3 of the patients, they had paranasal sinus involvement. And out of this, like the upper jaw involvement with the loosening of the teeth, I mean, is very commonly seen. This is not a standard features or the common features that we have observed in our 2 years back study, that loosening of teeth and the upper jaw involvement, which is probably very common in the COVID-associated mucormycosis. The 7 patient has the cerebral involvement or the intracranial extensions. 5 patient has pulmonary infections and 1 patient had renal plus pulmonary infections. In the CNS lesion characteristic, which is in combination with each other, like 2 had epidural abscess, 1 patient has discovertebritis, patient had the MCA infarct, 3 patient had the frontal lobe abscess, 3 patient had a temporal lobe abscess, skull base osteomyelitis, meningitis, lower cranial lobe palsy. I mean, so variety of combinations of CNS involvement along with the paranasal sinus or the ROCM was seen in this COVID-associated mucormycosis. Now, 37 patient has received a diagnosis by direct microscopic examination. So it is not that out of 47, only 37 direct microscopy was positive, because many of the biopsies were done outside and the ENT surgeon has not requested direct microscopy or the culture. And that's the reason that we have less number of patients who has direct microscopic evidence and the culture evidence. So 24 patient has culture positive and histopathological examination was seen in 42 out of 47 patients. All the pulmonary patients, like we did not have a histopathological diagnosis. The treatment, 70% of the patient has received liposomal amphotericin B. So this is a good number of patients, like compared to our previous study where we could not use liposomal amphotericin B in a large number of patients. 20% of the patients, they received deoxycholate versions of amphotericin B. The 5 patients, that is 10% of the patients, they received posaconazole as a first-line therapy for their mucormycosis, and the sequential posa or the ISA was used in 14 and the 3 patients. So in outcome, 6 patients, they left against medical advice, 5 patients died during hospitalization, and rest of the patients, they are still under follow-up and they are still receiving antifungal therapy. So these are the few examples of mucormycosis. Here you can see the cavernous sinus is enhancing, and there is a lesion in the temporal lobe also. So this patient is in cavernous sinus plus temporal lobe in the abscess. Again, another patient with temporal lobe abscess. The palatal necrosis because of mucormycosis. This is a histopathological, the findings of a patient who had a discovertebral mucormycosis with the psoas abscess, and this patient had rhizopus microsporus infections. This is the histopathological findings. The dual infection is also not uncommon. Out of this 47, 3 patients had a dual fungal infection. 1 patient has Aspergillus flavus, another patient has Aspergillus starius, and 1 patient has Fusarium infection. This patient has predominantly paranasal sinus involvement with the eye involvement. And this patient has both the evidence of the culture as well as the histopathology in the same the section. Here you can see that there is a septate, and here you can see there is a thin septate fungus mycelial filament. So this patient grew the Fusarium. So those who are into the fungal treatment, they will know the difficulties when you have Aspergillus starius, how you are going to treat these patients, and if you have Fusarium co-infection, how you are going to treat, because this Aspergillus starius has the intrinsic resistance to the amphotericin B, so you cannot go ahead with amphotericin B monotherapy when you have Terrius dual infection. And Fusarium also, it's highly resistant fungus, and half of the Solani, they have susceptibility to voriconazole, right? And even amphotericin will also work for these patients. So what we did for these 2 patients, we have combined amphotericin plus posaconazole to. So this is an example of pulmonary mucormycosis, reverse halo, big cavity, and you can actually demonstrate the vascular the invasions here. This is a renal biopsy slide. You can see that there is a vessel wall. This is vessel wall here, and this is the presence of the broad aseptate fungus into the vessel wall. Actually, that histopathology slide is from these patients, and this patient who, I mean, this is a very interesting patient. From North Gujarat, he came with flank pain, high-grade fever, and a little bit of hematuria. And he has just recovered from the COVID infections. And when we did a CT scan examination, so he had a sonography which showed the bulky kidney. So we immediately did a CT scan, and CT scan showed the infarcted kidney, infarcted left kidney. So even before making a diagnosis of mucormycosis, we just subjected these patients for a nephrectomy, emergency nephrectomy. So we convinced our the neurosurgeon that we need to do a nephrectomy immediately. And this patient CT scan also showed a thick wall cavity. And this is a kidney that we have removed very next day of hospitalization. And the kidney showed the invasive hyphal structure suggestive of mucormycosis. And you can see the artery, the lumen is full of this Aspergillus species, and which is producing infarct into this kidney. So just to summarize this, the fungal infections in COVID-19 infection, this SARS-CoV-2 is a potential risk factors for invasive mold infections, both Aspergillus as well as the mucormycosis. The treatment of COVID with either steroids or tocilizumab and the other the parameters like intubations, broad spectrum antibiotic, which will increases the risk of these invasive mold infections. The diagnosis of invasive mold infections is difficult and challenging because fungal biomarkers may not give you because of like concomitant use of plasma, concomitant use of tazobactam or the beta-lactamase inhibitors, which may cross-react with your fungal biomarker and may not support to reach a probable diagnosis. But it is a useful, especially when you are getting it done from the BAL sample. The mold infections in COVID-19 patient is associated with the higher mortality, especially the aspergillus as well as the mucormycosis. Treatment is very expensive because liposomal amphotericin B for a prolonged period is very expensive stuff, and it requires extensive monitoring for the side effects as well as for the drug-drug interactions. Thank you very much for the patients listening.
Yes, thank you, Atul, for a wonderful presentation, both highlighting the difficulties as well as how you have solved the problems for aspergillosis, as well as other molds, and of course for mucormycosis. So it's really a very interesting but very difficult problem for the patient. In fact, in a recent editorial which I had written, I called it as post-COVID mucormycosis from the frying pan into the fire. So the person who's already had such a bad problem with the virus is now going to get an even worse problem, and we really don't know finally which one is worse out of them, mucor or COVID. And I think a proper direction about management as well as suspicion and then management, and as soon as possible, perhaps makes a lot of difference. It's heartening to note that the mortality is not so high. I mean, at least many of your patients are still under follow-up and continuing with treatment. And I don't think late mortality would be a major problem. Whatever happens is they come with an extremely bad disease which is disseminated, and early mortality is much more likely. Once the patient is on efficient treatment, surgery is done, and effective drugs are given, then the late mortality becomes less. Again, you have highlighted that many patients would leave against medical advice at the prospect of this kind of mutilating surgery, which is going to be required, the cost involved, and everything else. So these are really big challenges for us. Thank you, Atul, once more, and thanks to all the three wonderful speakers. I think it's now time for questions. I don't know how to go about. Shall we go with the chat box? I don't know what is happening here. Okay, so one of the first questions here is COVID-19 management in immunocompromised patients, with especially a focus on HIV. And I direct that to Sanjay. Do you think that there are any differences in the management of COVID in this group of patients? I think you already answered, but please do again.
Yeah, I think as I have mentioned in my slide, there is no difference. At present, there is no evidence to suggest that HIV patients would respond differently as compared to HIV negative. So as we know, for HIV negative COVID-19, what predominantly is associated with the mortality is use of dexamethasone or steroids for low dose for individuals who need respiratory support. Low molecular weight heparin or anticoagulation in admitted patients, and maybe remdesivir in patients who need low flow oxygen. So apart from that, really there's not. But one thing which I would like to mention, which I also highlighted in my presentation, is be wary about if the patient is on a protease inhibitor, be wary about interaction with steroids, because these patients not only develop hypercortisolism, but as Atul has also shown, the risk for developing a further fungal infection secondary to high dose steroids. So continue ART in these patients. There is no need to change ART also, thinking that lopinavir may work. You know, there is this idea in between, people had this, that you should put them onto PIs. So no evidence for that. Continue with the same ART.
Have you come across any atypical presentation of COVID-19 complications in PL-HIV?
Actually not. When we analyzed our data, which I showed you briefly, actually majority of them are having asymptomatic mild to moderate illness, and I've not really seen any different presentation in terms from the COVID-19 perspective as well.
Right. Now, Manoj Shivkani is asking, what's the chance of fresh COVID wave in India in 2021? I suppose this is to be directed to Dr. Raman Gangakedkar. I think he has a crystal ball. He can look into it and tell us whether there is going to be a fresh COVID wave. I think we already are in one, although most people may not yet admit it, but I think we are seeing it. What is your take on this?
My take is only one simple. I know one thing, that it is preventable. I know if people raise the level of adherence to COVID appropriate behavior, we may not see second wave at all. The third thing which I would always say is entry of variants or variants that may be there within the country can also be stopped by the same COVID appropriate behavior. You don't need to change gears like you do for vaccine. So hopefully our people will respond. It's just that COVID fatigue is setting in, and I hope we will be able to avoid that. As far as if the second wave comes, then the issue will be slightly different. Second wave will come little more strongly in areas where first wave was smaller, because the type of population that tends to move out is likely to be more vulnerable population. And all of us know that the third Sero survey has shown that only 22% of the people have seroprevalence of COVID antibodies. Naturally, it would mean 78% are likely to be vulnerable. So let us hope we all work together. Let us hope all of us understand that we would promote people to take vaccine, because unless the people who belong to more than 50 years of age and those with chronic morbidity are vaccinated, deaths, impact of deaths cannot be stopped. And if we have to cater to this patient load, you need doctors who would also be protected. The healthcare workers also should be protected. I think we should not worry about variants as much. The numbers continue to be appearing as if they are not significant. So let us trust in what we have rather than, try to refuse vaccines under imaginary fears.
I think all these points are very well taken, and you used the word COVID fatigue. I would sort of modify that a little bit and say mask fatigue also, because and I think there has been a bit of a problem here that people have not been told that the mask is most important when they are talking. In fact, when people with deference to you, with respect, they try to lower the mask and talk to you. So that is something which is too funny. Not just funny, but it's not the right thing. People are talking very, very loudly on their mobile phones with their masks down. Even in closed spaces such as hospitals. I think this either people don't understand that or have not been educated enough. Wearing mask outside while you are taking a walk in the morning is probably not that important, but while you're talking, it is the most important time point is that.
This is allow me, I will add one more thing, that one of the most risky behaviors is related to the COVID appropriate behaviors that people tend to follow in home. No, it is more often than not, there are people who are moving out of house. They may not be following COVID appropriate behavior well. They come back with mild or symptoms that they don't recognize or are truly asymptomatic, and they eat together with the entire family. Right. You don't have the luxury of having 6 feet distance while eating in family household setting, and naturally the transmissions tend to increase dramatically. You find that entire family comes out as positive, which is actually a sign of COVID appropriate behavior not being followed by an index case, especially when the person is in household. The ventilation tends to be extremely poor. So one of the key messages that has to go out is anybody who feels that he has mild symptom or symptom that could possibly be classified as COVID related symptom should immediately isolate oneself. That perhaps is the best strategy until the diagnostic results tend to come. The reason that becomes important is 76% of transmissions, they tend to occur 2 days before symptoms appear and 2 days later after the symptoms have come. Now, if I manage to isolate myself when the first glimpse of the symptom comes, I might be able to reduce a large fraction of secondary transmission that tends to occur. And I think these messages have to go. What is also important is, as a doctor and in a democratic setup, you have been given right to refuse to take vaccine. But please ensure that your views, no, if you have not taken vaccine, should not be imposed on patients. Please provide them the correct information. Let them choose, like we did for HIV. Let them make an informed choice.
Absolutely. Very nice comments. And
Rajiv,
I hate to sometimes be a spoil sport, but in our hospital, or I suspect it's the same story everywhere. We find people having lunch together, and with a lot of gossip which goes along with the lunches, which get extended for a long period of time. I think that's an ideal setting for asymptomatic individuals to transmit to all those people who are their co-lunchers. This is a personal question. I was found COVID positive and was
Rajesh, just like a
hospitalized.
brief.
Rajiv, I have one.
Yes. Please do so.
So Ganga, I have one apprehension. Like Ahmedabad has 2 test match and 5 T20 match with a sitting capacity of 110,000 people. So government is allowing 50% occupancy. So at least 55,000 people will be watching this 5 T20 and 2 test match. Plus, I think the police and the other staff would be around 5 to 10,000. So large number of people, they are going to gather. So how we can maintain the social distancing, especially when the match is over and the entire crowd is rushing out for going home. So this is a big challenge that probably the Gujarat and especially the Ahmedabad will be going to face in near future, because nowadays, like, the number of cases, COVID cases, are rising in Ahmedabad.
Right.
I think it's a question of appealing to people to reason out. Do they really want to go on the field and watch the match? Can they not watch that match sitting at home on TV, which is giving them a better glimpse of what happens, rather than having that thrill of sitting in a crowd and trying to do that? What is also important is, it's not only this. There are multiple super spreading events. One is elections.
Yes.
Elections tend to happen, and if you look at the photographs that come, you tend to get scared. You have Kumbh Mela that is going to take place pretty soon. Now, we really don't know. And I think these should make us reflect and be serious about ensuring one's own health, one's own life, and also the health and life of the other family members. I think the only way we can appeal is more through reasoning, but at the same time, you have to have a small dose of emotion attached to it.
Rajiv, can I also
Yes,
make
sure.
a small different perspective which I have seen recently also, is that when the wave went down in Pune, and subsequently now that we are seeing news, majority, some of the patients who came to me actually have been to the primary care physician, and they have complained of COVID-19 symptoms, but they were not screened and they were not advised isolation. So I think primary care physicians at first level of entry of care need to be very sensitive to this. And at least, if not testing, testing is widely available, but if it not, at least isolate. This is very, very important. This is point of entry kind of a thing, which we did even in HIV.
Very true. And even about mucormycosis, most of the time, people will go with a, nasal discharge, which is bloody, or some initial symptom like this. And what is the knee-jerk reaction? Give antibiotics, sometimes do nasal douching, and sometimes even give steroids. So, we have a real long way to go in education of not just COVID, but Kappa and mucormycosis and every other health aspect. These are points. See, basically, people want to go there to have a good time, So what Dr. Ganga is saying, you can't have that good time in your living room with your own wife and kids around you. There, they want to be among very sort of raunchy audience who's going to cheer and boo and everything else, and they can't do that with their masks on, obviously. So again, we are going to play spoil sports in all these events, but we have the good of the people at our heart. Anyway, so somebody who's had recently COVID, when is that person set to take the vaccine? Anyone wants to take this question? I think it's quite well settled and it's well set out in various guidelines and forums. But yes, anyone would like to take that question?
No, the best is, I think, you should answer rather than anybody else, because then you would be truly playing the active role.
Who, me or the person who's asked the question?
You.
I should answer. Okay. So if somebody has has already had infection, it is very less likely that for the next 90 days the person could get a second infection. Overall, second infections are also not very common. But even if they are going to happen, it's very rare earlier than 3 months. So it makes great sense to postpone the vaccination for 3 months. There's also a move in some circles to give them only one vaccine and save the second shot for some other needy person. And so definitely one can postpone it for 3 months and take maybe one, if not 2 shots.
Yeah, also important perhaps is also one factor that if the outbreak is raging in the area, it would be prudent policy, because we say one dose doesn't protect you. So the earlier you take vaccine, it would be better. But what is earlier? If you have COVID infection, then it tends to have immune suppression, which may be lasting longer. So any period that generally that tends to recover in 2 weeks time. So any period after 2 weeks could be a good time to get yourself protected with vaccine again.
Yes. Okay. So what is the vaccine effectiveness against the variants? And I think Ganga has already answered that question, but maybe emphasize it once more. So you have the UK variant, you have the Brazilian, and you have the South African, which are the 3 most important ones. So
the UK variant is covered by our own vaccines.
yes.
When it comes to South African variant, there is a doubt whether it will cover. But as I said, the likelihood that South African variant would enter in India is very low as of now, mainly because one thing which we have to recognize. I was surprised. I was asked to deliver a talk for Indian fraternity in South Africa. And when I asked them what is that number like, no, they said perhaps in South Africa they have about 5,000 odd Indians who may be families which may be living there. So the likelihood of even transmission is going to be far lower, especially since the wave that they were facing is on a great decline. And what is most important is most of the evidence that we are getting is still not robust enough to say it doesn't protect or it protects. No? So it would be worthwhile taking that vaccine. If ever you require another vaccine to cover yourself against a variant, there is no way, but we will have to provide some other effective vaccine later. But as of now, we should worry about the common variant that we are facing and try to protect ourselves.
Right. The next question comes from Dr. Bakchi, and I think he's a pharmacologist because he's asking about something like pre-exposure prophylaxis. Is there a role for prophylactic medications for the general population in high incidence areas in India to reduce the presence, replication, and transmission of the virus in the society?
To be honest, no, you have Eli Lilly, you have monoclonal antibodies which are being developed for pre-exposure prophylaxis. But to my mind, providing pre-exposure prophylaxis, you need to have sufficient time to administer the same in order to be effective. Now, it is more likely that people don't recognize exposure, and then it becomes very difficult to provide these monoclonal antibodies. What is also important is monoclonal antibodies that they have are also likely to generate escape mutants over a period of time. That's why my own individual gut feel, which for which we had some discussion in the national task force, was perhaps we should refrain from providing these monoclonals as pre-exposure prophylaxis, given the fact that the more we are learning about this virus, the if the outbreak is severe, we shouldn't use that.
Has there been a concomitant decline? Sorry, Sanjay, you want to add something?
Just to add, I think since he's a pharmacologist, hydroxychloroquine is done and dusted. So for prophylaxis, so
yeah,
that's gone.
What about pangolin scales? Do they help?
There's no RCT still.
Okay. Has there been a concomitant decline in the incidence of TB, especially pulmonary TB, due to the wearing of masks in India? So Atul, take this one. You are talking mainly of fungus, but there is another mycobacterium there, which is very important.
So, I mean, we are keeping, the data on the newly diagnosed tuberculosis. So I just looked at my 2020 data, and I also, feel that like the new TB diagnosis in my clinic is mainly extrapulmonary rather than the pulmonary during this 2020. And probably, I also believe that probably the masking, universal masking, will limit the transmission of new tuberculosis and reduces the number of new TB. So all these extrapulmonary TB, most of them, they have reactivation of disease because of either uncontrolled diabetes or some immunosuppressive therapy for their collagen disease or something else, right? So I think, yes, probably the universal masking will help to reduce the TB transmission and the new TB cases, but the extrapulmonary TB will continue to have the same number.
Yeah, actually, this has also been studied under RNTCP. The new diagnosis has dropped down dramatically, even for TB. But until the time we have evidence that the death rates among those undiagnosed TB cases, because they couldn't go out and get themselves diagnosed, is not higher, we will still refrain from saying that TB has been impacted in India, pulmonary TB.
And again, if someone has a mask, doesn't mean that he cannot spit. He can remove the mask and spit wherever he wants. Tridip has asked this question. What is this controversy about 8 to 12 weeks gap between two doses of Covishield? I have taken with a 28-day gap. So does it mean that I am really not well immunized? Tridip, you have been the guinea pig already. So now thoughts are evolving whether you should increase the gap. 8 weeks was what was tested, and therefore that is what you have done. But maybe postponing it a little bit may be a good idea. Anyone else has any thoughts on this?
Yeah, just issue here is that the Lancet yesterday published this data of increasing the dose. The authors themselves mentioned this is an exploratory analysis. So essentially, of course, it looks like the trend is that the further you dose it, dosing interval, you will perhaps have a better protection. Efficacy is better, but it's an exploratory analysis. Remember, it was not powered to really look into these issues as a research question. So I think, of course, there's also emerging data for Pfizer as well, that, prolonging the dose. So it looks like it's not just a vaccine phenomena, but it's across the platforms, maybe delaying the dose. But the Pfizer dossier, which they submitted to the US FDA, had this evidence. But Pfizer itself said that, they are not recommending prolonging the dose. It's up to the regulatory authorities to decide what to do about it. So I think this is a little controversial, but I think it's not an easy answer. Maybe Ganga can put in, or Atul can put in.
I'd like to say something here, because see what happens when they plan a trial. See, if you really see about other vaccines and so on, the booster dose should be a little bit longer, because that's what I gather from understanding of general vaccinology. And probably this 8 weeks was a compromise because they wanted to finish the trial. So if you have a interval which is very, very long, then you cannot, this is an emergency situation where some data needs to be generated fast. So I personally think this 28 days has come from that rather than real science. And it is quite possible that postponing the second dose may be beneficial. Ganga, your last word on this.
No. Mine cannot be the last word. The last word has to come through evidence, to my mind.
Yeah, that's true.
What is most important is, if you look at AstraZeneca trial, the quality of conduct of that trial is also under clouds. No? Now, this irregularity of providing vaccine late was not a planned irregularity. It happened accidentally, and then they thought it could be regularized. That's number one. Number two, what is more important is, when they are comparing that, you find that the confidence intervals are overlapping for all these three periods which they try to compare. So it would essentially mean you would get the same amount of protection if you are giving it at 28 days, maybe 6 weeks, maybe up to 12 weeks. That's a conclusion which they want to draw. But they are using this particular logic to say that you can postpone taking the second dose only to suit the people deciding that single dose vaccine, there could be a longer coverage. Now, there could be questions which people will ask. One question is, is it that this is also now an issue of marketing, no? If I provide the same vaccine to a large number of people using one dose and increase the gap, no, you will find that my market that I will capture will be higher enough. That suspicion cannot be taken away. The second issue, which is also important for us to recognize, is they are using same adenovirus vector in first and second dose. Now, if I am using same adenovirus vector, one of my worry, which is unlike Sputnik, is would I develop antibodies against, after the first dose itself, the virus that I'm going to give later, and how effective will that be later? To my mind, the longer you will delay, you will perhaps mount a very strong response against that adenovirus when it comes second time. If you are coming into a closer space, with respect to first dose, perhaps that might be lesser. But as I say, nobody's word can be the last word. I think it is evidence which has to be generated, which needs to be robust before we alter our approaches to provide the second dose based on evidence.
Yeah, but can I ask you a question here, that even if you have a robust immunity against that particular chimp adenovirus, what does it matter? The immune system is going to, in any case, destroy. This virus is a non-replicating virus in our own human body. And finally, the operating part of that whole vaccine is the anti-spike, the spike genetic code. So that even if the virus gets destroyed by our immune system, is it going to destroy that genetic code?
Absolutely. No, one needs to understand that this particular virus will be destroyed before it gets into my cell. No?
Okay.
And when that happens, the mRNA is not going to be, the DNA is actually not going into the nucleus to produce a spike protein. The genes that are encoding the spike protein have to reach the nucleus, and only then they will produce it. But that may not happen. So therefore, there is a room to suspect that, and one must also remember that when Sputnik came out with a design where you have AD26 and AD5 as separate viruses, which would be provided in first and second dose, one of the responses was that we should have interchangeability study between AstraZeneca and also Sputnik, because then two dosages will come from different adenoviruses, and that might help us ensuring that the immune response is stronger.
Yeah, can I just add the experience of using adenovirus vector for HIV vaccine in the STEP study? There was a STEP study which was done, and they actually demonstrated that, you know, patients who received the MSMs who received this vaccine had a higher incidence of HIV. And one of the explanations for this was anti-adenovirus antibodies.
No, I didn't get you. Was it countering me or?
No, I was just adding to the information about why adenovirus antibodies are important.
Absolutely. Actually, if you look at it, that's the reason all these companies, whether Sputnik or AstraZeneca, they have chosen adenovirus strain which either has not been known to infect human beings, because presence of adenovirus antibodies in itself reduces the take of adenovirus vector based vaccines.
Okay, there's one more question. It's continuing the same question. So if that short interval vaccine of 28 days is inferior, will I require a booster after 6 or 8 months as compared to 12 weeks gap? I think it builds up on the same issue. I think we'll go to the next question. The conflicting reports of benefits of remdesivir, any opinion on this?
पुजारींना सांगू द्या ना.
So you like the WHO trial or the Act 1 and 2?
Yeah, overall, I think now guidelines, if you really see guidelines, there is synthesized evidence, there is an NIH guidelines, IDSA guidelines. So all of them really recommend remdesivir only in the context of patients who require low flow oxygen. So apart from that, it may not be really beneficial for patients who require high flow or invasive ventilation or non-invasive ventilations, and also in patients who do not need oxygen. Remember, remdesivir has not shown mortality benefit in any trials. So it is just shortening of the duration of symptoms. So in that context, currently in my practice, I'm only using it in patients who need low flow oxygen.
How reliable is serum galactomannan for aspergillus, as it is influenced by various drugs, etc.? Is there some high cutoff value to improve sensitivity? I think what you're addressing is actually specificity.
Yeah.
Does Bal galactomannan also suffer from the same deficiency?
Yeah, obviously, like, so when we talked about the interpretation of galactomannan, we need to understand that this galactomannan is actually initially studied in a neutropenic host. So here, like what we are talking about non-neutropenic host. So in neutropenic host, the serum galactomannan has an immense value in monitoring the patient who is being diagnosed to have aspergillosis, or to picking up early diagnosis of patients having the suspicions of aspergillosis as a cause of fever in febrile neutropenic patients. The reason being that the patient who has a normal functioning neutrophils, these functioning neutrophils will take away the galactomannan from the serum. And that's the reason that we are not getting the positive value in non-neutropenic setting who has the histopathologically evident invasive pulmonary aspergillosis. So to answer your question, like in non-neutropenic patients, if you are looking at very high galactomannan, try to find out a reason for that. And most probably it is a confounding factors like the BLBLIs, the most common would be the tazobactam, which will give you a false positive, the blood products, immunoglobulins, plasma, all these things can give you a false positive galactomannan. right? So we have to be very careful in interpretation of this galactomannan. So increasing cutoff in non-neutropenic setting will not give you any additional the specificity parameters.
Right. And it's very interesting to see this particular case, and we all of us have seen this type of cases where the serum galactomannan is actually many times higher than the BAL galactomannan. Now, if we are thinking that the disease is in the respiratory tract, then the BAL galactomannan should have been many times higher than the serum, especially in a non-neutropenic patient. Where here you have entirely the opposite story, which tells you that this is definitely coming from the administered drug or something like that, which is giving you false positive. Whatever you infuse by intravenous means, it's unlikely to find its way into the BAL. Okay, so BAL galactomannan will be something which is generated in the respiratory tract. Krutarth is asking this question. Any role of positive serum galactomannan in diagnosis of kappa? I think you have already addressed this issue. Now, your experience about isavuconazole, posaconazole monotherapy in COVID-associated mucormycosis, role of combination, pending final diagnosis in severely ill patients, do all the mucorales cases need source reduction? By that he means source control or debridement.
Yeah.
Quick answers to these questions.
Control is very important. So to take care of any invasive fungal infections, especially the mold infection, so you need to debulk the disease. So if somebody is having paranasal sinus involvement, so try to debulk the disease by repeated debridement, repeated sinoscopic debridement, and that will reduces the necrotic area where the replicating fungi are there, and we are not expecting a drug penetrations into this center of this necrotic area. So source control is extremely important to improve the outcome of the mucormycosis, not only in COVID, but the mucormycosis alone also. This is number one. I don't have experience of using posaconazole or isavuconazole monotherapy, except like in this current cohort, like some of my colleagues, they have used posaconazole alone because of the obvious reason patient has pulmonary mucormycosis with compromised renal mucormycosis patient who had compromised renal functions and expecting the severe the AKI during the initial therapy. So this patient will continue with the posaconazole monotherapy and is doing well, but it doesn't mean that posaconazole is the treatment that you can choose for mucormycosis as a first line. The liposomal amphotericin B is still considered as a first line therapy, and one should not deviate from using liposomal, going for an oral therapy.
Right. Yes.
And of course, like monotherapy is current guideline says that monotherapy is the recommended for the treatment of mucormycosis, but for exceptional cases, you may go for a combination therapy where you are predicting that because of these comorbid conditions, renal conditions, and any other issues where the tolerability of liposomal amphotericin B is questionable. So patient is not going to have continuous amphotericin B infusions for a longer time, where you can start them with the oral therapy with the hope that even though like you have interruptions in the liposomal, patient will continue to receive one of the important antifungal agents for his life-threatening fungal infection.
Yeah. You know, maybe Atul can go on with this issue of combination versus monotherapy for mucormycosis for an entire session, and still at the end of it, we might not know what is the right thing to do. But you know, all of us have seen patients where monotherapy has been given as a because of accident. In the sense, what Atul said, that there is going to be an interruption for whatever reasons. The patient just goes away, and if he's going away, now like in the study, 25% patients go away. So if they're going away, what are you going to do? You're going to give them monotherapy. And believe me that some of these patients have done well. Now that doesn't mean that that is the way to go. The way to go is definitely liposomal and not monotherapy, but rather than sending the patient away without any treatment, maybe you can try the monotherapy. Now, which of the available vaccines for COVID is preferred in HIV patients? So, do you know the answer to this, Sanjay? Do you know the answer whether it is preferred in normal people, whether it's preferred in HIV patients? What is the right answer here?
So I don't think there is any particular preference. The issue really is twofold. One is safety, reactogenicity, and of course efficacy. All platforms we should remember, all been tested in HIV positive population prior to the COVID in HIV negative population as well for HIV vaccines, and I don't think it should be an issue. There's no evidence that one should prefer one or the other as compared to HIV negative. I don't think there's an issue there.
Yeah. Leaving aside the confounding variable of being HIV positive or negative, can Dr. Ganga Kedkar tell us a little more about which vaccine is there anything to choose or prefer, or at this moment we can't answer that question?
No, you can answer the question.
Okay.
Basically, one has to understand one thing, that whatever we are injecting are not live viruses in classical sense. The only live virus that you are giving is adenovirus, which is of non-replicating variety. So essentially, it is not going to affect them by any means and produce any infection. So we should go ahead with whatever vaccine is available to us. The only issue that will perhaps be important is how protective these vaccines will be, given the fact that the take of vaccine may differ based on the level of immunosuppression which HIV infected people will have. That should not be mixed with provision or a vaccine in particular. I think that's an overall phenomena that one needs to worry about and not otherwise. So any vaccine can be given which is available now. Now, if there are newer vaccines which will come, let's say a nasal vaccine which is live attenuated, there would be issues. But as so far as the current vaccines are concerned, there is no issue.
I think what is in the mind of the person who asked this question is, which one is more immunogenic, which one is maybe safer? Can you sort of throw a light on this question?
With respect to immunogenicity, the best way to judge it simplistically is look at the local reactogenicity and the systemic side effects that tend to occur, and they occur more with Covishield. So perhaps it could be one of those vaccines which may give better responses as immunogenic vaccines.
Yeah, Rajiv,
Yes,
I think
Uptake.
when we talk about the HIV and vaccine, like we have to, divide HIV patients into two broad groups: newly diagnosed and patient not on antiviral therapy, and patients on antiviral therapy with controlled disease. So I think patients on antiviral therapy with controlled disease, they are immunocompetent hosts. They are absolutely, their behavior is like any other uninfected patients. So they can receive like whatever vaccine that other people are getting. But for those patients, those who are not on antiviral therapy, those who are immunocompromised, newly diagnosed with low CD4 count, here I think the live attenuated vaccine is out because of the risk of infections like nasal vaccines and other things. And the immunogenicity of the vaccine comes into the picture because of the low CD4 count and not being on antiretroviral therapy, not having immune reconstitution. So those patients with controlled disease, I think we should not, describe them as a HIV infected patient. They are just like any other immunocompetent host.
Right. So after the second vaccine shot, is it recommended to check antibody levels maybe after 2 weeks? This is again asked by Tridip.
No, it may be an option, though we clearly don't understand what are surrogates of immune protection. Yeah? We must remember the only studies that have been done so far are among animals, where in animals they found that anti-RBD antibody titer of anything above 137 is considered as protective. But human studies don't exist as of now to classically say this is a surrogate of protection. Now, where would it be important to even take help of doing antibody testing? Those who are older, those who belong to old age group, there would be a fear that some of them are likely to be non-responders. So even a response can perhaps be tested just qualitatively, but we'll have to wait for a good surrogate to come.
Right. I think we've answered actually all the questions which have been posed, and very nicely too. So with this, I think I will turn it over to back to the organizers uh, and thank them once
Thank you,
again for a
sir.
very wonderful session.
Thank you, sir. Thank you very much. I think it's been wonderful. We could not have got a much better and apt faculty to discuss an important issue like COVID and concomitant infections. I mean, in 20 years of my career, I have been listening and grown up listening to most of the faculty that are there here. And the feeling is always like this, like to hear more and crave for more from them. And that is visible from the kind of questions that we have been listening from the audiences. So I'm sure that the participants had a wonderful understanding about the topics that we had today. So with this, we thank our chairperson, Dr. Rajiv Soman, and the speakers, Dr. Ganga Ketkar, Dr. Sanjay Pujari, and Dr. Atul Patel. So it's been wonderful, sir, for having you here with us today and for sharing your valuable insights. And also, I thank my colleagues and friends and also our IT team for providing the platform, the seamless platform, I must say, for organizing this webinar. We'd like to have more such interactions and presentations on the issues that we are currently facing. And I'm sure that we'll make it a good platform for the medical fraternity to interact with. So thank you very much, sir. With this, we'll close our today's webinar. I thank you once again. Thank you.
ये पुजारी का चक्कर क्या था? पुजारी ने उसका जो स्पीकर था ना, वो बंद था स्क्रीन के ऊपर, but we could hear him speaking. It was very difficult to understand. His last answer was at that time point when it was showing red color and he was still audible. वो क्या दूसरे मोबाइल से लगाया था क्या?
I think उसका bandwidth कम था, इसके लिए the video part of it was not coming. Only audio was coming.
My gut feel was he doing